بسم الله الرحمن الرحيم. في البداية بحب أشكر أستاذة الدكتورة أمال بشلاوي وأهنيها على المؤتمر ال19 لجمعية أنيميا البحر المتوسط. ونبدأ الجلسة الثانية. I have the honor to introduce my dear friend Professor Baba Inusa, consultant hematology and director of Sickle Cell Program, Evelina Guy's Hostel, UK. He will talk about sickle cell nephropathy current understanding.
Good morning. Again, it's a privilege to come to your meeting. Amal, thank you, and thanks for the whole team for giving me the opportunity to talk to you about some of the areas that I think I'm very, very interested in. And that is the reason why I'm interested in the renal problem in sickle cell disease is because when we were monitoring for other complications like hearing and like iron, I know exactly what tests to do. But actually, when I was to monitor for renal problems, I had no idea what to use. And I had a lot of discussion with a nephrologist, and so we're coming with this particular direction. And so what I want to do is just do a brief introduction. Obviously, most of the things have been discussed before, and then I'll give us a case study. A case study is, I presented this case before. It's a 13-year-old girl with sickle cell disease, does have a lot of multiple complications. And so sickle cell disease was very, very little in terms of impact on her life, apart from the fact that she had short stature, she had a very good hemoglobin level. Hemoglobin F was also very high. And so it was quite very well. But also we had a few problems because the short stature gave some injections and reacted in terms of growth development. And then suddenly in 2015, this child presented with acute problems, acute renal failure, but actually it turned out to probably to be more than acute renal failure. And as you can see here, a lot of the electrolytes were abnormal. The urea was very high, creatinine was very high. And I also asked a question. I said, okay, what other lab result would you ask? If I have opportunity, I will hear you what you want to say. But these are some of the investigation that we had. We had a protein creatinine ratio that actually kind of reflecting back actually had been abnormal gradually, and actually at that time was at peak. And this was the creatinine level, and it actually had been rising, and obviously here it was at peak. So obviously there was acute on chronic problem. Potassium was very high. And the ultrasound actually showed a lot of changes, and which are actually kind of pre-existing this particular presentation. What was the impact of sickle cell disease in this problem is difficult to say. But obviously, I just wanted to go through some of the brief issues, particularly in terms of the sickle cell phenotypes. We know that obviously when you look at the severity, we are very familiar with the fact that SS and SB20 remain probably the most severe forms of sickle cell disease. But what are some of the risk factors in terms of generally severity of sickle cell disease? Hemoglobin F, we found out that actually is something that is quite significantly very important. In terms of kidneys, okay, so what are the kind of challenges, particularly in the kidneys, and what is the pathway? So this is just a schematic representation of some of the various things that actually could go wrong or probably could affect the kidneys. A lot of oxygen species, and then the consumption of nitric oxide as a result of cell-free hemoglobin, and all of this affect the endothelium and lead to kind of a progressive damage and a progressive vessel occlusion, and subsequently further kidney impairment and kidney damage. And so obviously this is a very good setting in terms of damage to the kidney. So from the red cell to a lot of adhesion molecules and a lot of things that actually kind of release. And so here I just wanted to kind of just show exactly what are some of the kidney pathology when you kind of want to classify renal failure, and want to classify that obviously based on the GFR, and you can see obviously the high GFR which we commonly see in sickle cell children, obviously in terms of the stage 1, but you can see the progression towards progression to the severe form. One of the things that you could look at here was there is no clear relationship between albuminuria and a lowering of the GFR. You could see that people could have normal albuminuria and actually yet have very abnormal GFR. So it's not a direct relationship, but obviously there are more abnormal GFRs in the very low, abnormal urine protein in the lower GFR areas in terms of the lower section. And the kidney is actually quite an environment that is not very good for sickle cell disease because of the nature of the blood flow and the nature of hypoxemia. But actually so much of the blood is in the kidney at any one time, a very high cardiac output. And again, in the kidneys, the pH is also kind of very, very kind of, because of acidic environment, and also there's low hypoxia. There's hypoxia, and all of these combine to be a very hostile environment for the sickle red cell, and therefore a very risk of having further problems. And so we really need to pay attention to the kidney because the kidney is a very important area. But unfortunately, before you actually find out some of these abnormalities, it's almost already very late. And you can look at those two kidney images, the normal one, and also the abnormal one in terms of the destruction of the architecture because of repeated vasoconstriction, hypoxia, and a lot of things that actually go further. So this slide was actually, so sickle cell disease, sickle cell nephropathy is a very complex term, and it's something that begins very early in childhood. Actually begins very early even as infancy. And obviously the progression can get into end-stage renal failure. Lead to chronic kidney disease when you talk about a drop in the GFR, but actually subsequently to end-stage renal disease when there is inability to handle all the products on the basis of the kidney function. And the incidence of kidney impairment or end-stage renal disease in sickle cell disease, when you compare that with diabetes we know very much that diabetes is a risk factor. But actually, if you compare it with the diabetes, a patient who has had diabetes for 30 years, the prevalence is 3.3%. But actually, the person who has sickle cell disease at that time is actually about 13%. So sickle nephropathy is much more, more at risk compared to those patients who have diabetes. And so in terms of early stage sickle cell nephropathy, if you look at the histology, is characterized by glomerular hypertrophy and a lot of deposits as well, because there's so much blood flow into the kidney. And then again, areas of hemorrhages and necrosis are all kind of interspersed between them. And then the most common renal histopathology is actually the one, the focal segmental glomerulosclerosis. That's probably one of the most common in sickle cell patients' pathology. But again, there are a number of other things could actually be seen. And so chronic kidney impairment in sickle cell disease is something that once it starts is very difficult to hold. And it's also, progression is very downhill. The progression is, obviously, when you get to dialysis, particularly adults will understand that. And also when you consider kidney transplant, again, the risk is actually still very high in terms of the damage to the kidney that is transplanted. And there are a lot of arguments now whether, if you want to do a kidney transplant, whether you want to combine that with bone marrow transplantation. If you have a HLA match, a patient sibling, or obviously if you can afford it. So the risk factors associated with progression of chronic kidney disease to end-stage renal disease, hypertension. And it's important to actually monitor hypertension. It's important to monitor and manage hypertension in sickle cell disease. And we're fully aware that blood pressure in sickle cell patients tend to be lower than the standard population. And hypertension in sickle cell disease apart from the fact that it's really going to affect the kidney, we know that it's also associated with silent cerebral infarct lesion, as well as stroke in sickle cell disease patients. So I think we should make sure that we monitor our patients very carefully in terms of blood pressure monitoring. And some of the other problems that are also risk factors include particularly the Central African Republic haplotype, the Bantu haplotype, and also APL01, which is also risk factors that have been described. But also something that is quite common is parvovirus B19 infection. This is something very common. Even though there could have been some immunization that is not made available, but that actually is a major problem in sickle cell patients. So I just tried to kind of demonstrate some of the bioschematic drawing. Again, this is in the chapter that we wrote recently, that just recently been published in terms of risk factors for renal impairment. Hematuria, even though it's very common and actually very scary, sometimes it's not necessarily a major problem because the mechanism with clotting and everything will just encourage hydration. But again, people kind of describe that probably the left kidney is probably more at risk. The other thing that's I think really comment very clearly is the role of acute kidney injury. And one of the things that we actually induce is the use of a non-steroidal anti-inflammatory. I'm absolutely very guilty in the sense that I use non-steroidal anti-inflammatory drugs in sickle cell patients very, very consistently. But because of the impairment and the risk associated with this, I think we need to be very careful. I think we need to be controlled, particularly to make sure that our patients are not really kind of disadvantaged by actually leading to acute kidney injury, which would progressively lead to further changes and probably impairment in the kidney function. So it's something that we need to actually kind of continue to consider. You can think about the changes in terms of medullary hypoperfusion, but also think about cortical changes that also could happen, and vasoconstriction and cyclical vasoconstriction, oxygen radicals and oxygen continue to kind of re-oxygenation and lead to kind of further damage. And this thing that actually would lead to further problems. And we know that although this particular diagram is not really what I've observed in my patients in terms of hemoglobin SC, because I find macroalbuminuria or albuminuria actually much common also in my hemoglobin SC patients. But some of the literature seems to suggest that hemoglobin SC is low. When I look at it and compare it, I actually did not find a significant difference between my patients. So again, rather than calling macroalbuminuria, we would prefer to call it albuminuria nowadays. Some of the risk factors, apart from APOL01, there are other genes that have been kind of characterized and actually have been studied quite extensively in diabetes. And we think this is time now to actually begin to look at some of the genetic markers in sickle cell patients. But this review is very good. It actually reviewed according to the different ethnic groups, Europeans, Arabs, Africans, and actually showed the risk factors for renal impairment. And there are kind of clearly defined 19 haplotypes that were actually identified associated with kidney impairment in Africans. But one of the studies is to try and find out, is there any kind of correlation between some of these genetic markers, these SNPs, and also sickle cell disease. And then we, in the SIT study, which participated, and I think, so we had about 900 patients that were characterized, and we reported GYs. We however, did not have albuminuria to actually compare that with the risk, with what we actually reported. So it would be nice to know the relationship between some of the GWAS and also some of the kind of SNPs that are actually been identified here. And here, this one actually kind of showing that some of the SNPs that were associated with hypertension, associated with renal impairment, so the colors actually quite significant, but the one that had red are the one that had a much closer relationship between renal impairment and diabetes. And also, so we need to find out what are the SNPs that actually might be closely related to sickle cell disease. And so the other thing that we try to find out in terms of the relationship between kidney impairment is the level of oxygen. Because we're shown in London, phenylketonuria, that low oxygenation is associated with stroke. But actually when we found out is low oxygenation associated with albuminuria, also is it associated with the risk of renal impairment. Obviously we were able to kind of demonstrate albuminuria as being a risk factor, and this was a question to identify whether there is an association between obstructive sleep apnea and or low nocturnal oxygen saturation with proteinuria. And this was a finding that the only thing that we found that was significant was actually, two things, was the percentage nighttime saturation, if it's less than 95%, and the minimum overnight saturation. The other ones were some of the sleep markers were actually not particularly related to the risk of albuminuria. So obviously low oxygenation will be something that we can actually do. And so the question is that how do we actually assess for renal impairment? That was the primary question that actually kind of came into my mind when we were monitoring our patients. We actually had difficulty in actually kind of assessing what else can we do to actually assess for renal impairment. And we use a creatinine. The creatinine is actually overestimated because of hyperfiltration. And I know the adults are actually much more happy with their own estimated GFR. In pediatrics, it's much more of a challenge because most of the markers are actually quite difficult to estimate and to be clearly kind of associated with. So some of the markers that actually come into to kind of really light is actually among these ones that I've actually kind of demonstrated. But cystatin C and the NAG are probably quite interesting. NAG is particularly predictive of acute kidney injury, whereas the cystatin C is much, because obviously when we want to look for a GFR measure, we want a marker that actually it is not secreted. If you offer it is not secreted, it's not absorbed, and actually you can pass it through the kidney and measure it properly. Cystatin C probably may be something quite close to that. Obviously, there could be some variation, as some people actually have observed. So you can look at the NAG, you can actually look at where we can actually easily measure. So looking at the markers will be something that we think will be very, very helpful. So we're trying to see, okay, adults have been very excited about cystatin C. It's a non-glycosylated, low molecular weight, basic protein that inhibits cysteine proteases, and it has been demonstrated closely related to GFR, and it crosses the glomerular membrane quite easily. And so this may be very close in terms of what we're looking for a very good marker that will allow us to assess GFR. The other one is the NGAL. Again, this is filtered across the glomerulus, although many investigations have actually suggested that it's used in terms of AKI prediction, we still need to kind of study in sickle cell disease, and I think it's worth paying attention to it. So our cohort of patients that we actually looked at, we used to use the modified Shores formula. We call it Shores Haycock because Short Haycock identified the formula. Haycock was the professor in our hospital, so we combined the two names. But actually, it's something that is useful, but you have to measure the height, and you could have some kind of problems with that. So we're trying to see if we can actually get another biomarker. So we used creatinine measured by mass spectrometry. The reason is that if you measure creatinine using the standard enzyme, it can be actually increased by the fact that you have bilirubin and hemolysis. So if you probably use mass spectrometry, you probably will eliminate that and allow you to measure the creatinine in a more reliable manner. So we're trying to measure the creatinine compared to Inutase. We compared it with Inutase, but subsequently compared with iHexol as the gold standard, and to see whether the correlation was very good. So in initial sample, we actually found a very good correlation. However, subsequently, as we increased the number of patients, and we then increased beyond the transfused patients, we actually began, the correlation wasn't as good. So therefore, we really want to find out whether probably cystatin C may be much more reliable. And so this is kind of looking at our patients in terms of the albuminuria over time, and you can see over time it's continuing to rise. And I think it's important to, when we talk about monitoring, it's important to actually monitor the albuminuria and to see the progression. I'm trying to correlate the albuminuria with the GFR, and actually it wasn't correlating very well. So this just goes to the fact that albuminuria is not necessarily associated with kidney impairment, with GFR falling, but actually it is a good predictor, but not entirely correlated entirely. But those patients who are on hydroxyurea, what happened to the albuminuria is beginning to drop over time. And I can show you some of my patients, particularly the adolescent patient, albuminuria is very controlled when they were on hydroxyurea, but as they became adolescent, adherence, taking the medicine became much more difficult because they're out of the parents' control. And you find out that the albuminuria begin to come back and begin to rise. It might necessarily be a factor of age, but also it might be a result of adherence with medication. So this was just the one we tried to correlate albuminuria and GFR, and there was no very clear correlation, although there was a trend going upwards. So obviously in terms of the treatment option, so what is the role of hydroxycarbamide? What is the role of transfusion? And what is the role of stem cell transplantation? And obviously we're thinking about gene therapy, and it's very exciting seeing the most recent report in the New England Journal of Medicine showing the possibility of stem cell transplantation really kind of making a lot of progress. And also the other aspects are gene editing, which are also very important. But it's important to make sure that we control blood pressure, adequate hydration. But I think the other thing we need to worry about is the use of analgesias, anti-inflammatory. This slide I got it from a recent report, and actually just try to summarize some of the treatment strategies that actually might be very important. And I was asked a question yesterday about hydroxyurea. Yes, in my clinic I offer hydroxyurea to children with SS and SVT0, irrespective of their symptoms. Again, it's not so easy for parents to really accept. It takes some time through parents and through some other siblings, because, for example, if you started hydroxyurea in one sibling, the sibling gets better, and then the other sibling say, okay, what about me? And then it gets on. But sometimes parents takes a while to actually begin to accept hydroxyurea. But I think hydroxyurea, looking at the mechanism of action and the fact that it will reduce the vasoconstriction, I mean, a lot of hemolysis leads to consumption of nitric oxide. By doing all of those ones, I think hydroxyurea certainly would be a very good option in terms of some of the treatment. I say, okay, this is just a summary to say, okay, let's consider monitoring these patients. This pediatric slides, okay? So adults, you can make up your mind. But in terms of pediatrics, monitoring is important, and I think I would definitely encourage people to do albuminuria. Obviously, if you use albumin, if it's low or high, if it's high, you use protein creatinine ratio. It's very simple and it's easy to collect. I tend to collect for all the children from the age of, say, around 4, 3, if they can make the urine. I will not stop them from going home if they come to clinic, if they can't make the urine. But if they can make the urine, I try to get it. But what I think we've done also is to try to get early morning urine to try and assess for their an average. So early morning urine will probably be very, very helpful, particularly in a research situation. Obviously, in a clinical setting, I think it's important to. So I think my take here is, and my challenge, however, is that we're still trying to identify what is that marker. Will that certain C looking very promising, or will creatinine estimated marker, which adults already are using, would that also be very good for us to monitor? And if you monitor, what can you do? And I think prevention is also very important. I think the use of analgesia, non-steroidal anti-inflammatory drug is something that we need to be very careful about. So I want to just acknowledge some of my friends and colleagues in Oxford Genetic Laboratory, and these were involved in analysis, and actually they are one of our collaborators in trying to find out if there's any genetic marker that we can identify. My colleagues, including nephrologists, and my team, and King's College Hospital. I want to say thank you, but let me just say something which is completely commercial. Not commercial, actually, but because I have a conference in October, I thought I might want to show you my conference. Is that okay, Amal? Okay, all right, good. So she agreed. So we have a conference in October. I thought it was going to just go in online. All right, it didn't. This is not connected. This is absolutely disappointing. I thought I was going to just show you by clicking on it, and so this is not connected online. Okay, all right. I missed the opportunity. So thank you for giving me the opportunity to talk to you, and good morning. Thank you.
Thank you, Professor Papa Inusa, for this illustrative talk.